Have a couple of nodules here and there in your thyroid? Don't worry, they're actually quite common and usually benign. So throw away that outdated turtleneck, my friend. In this sketch, we're going to illustrate a few disorders that can cause thyroid nodules. Why is it important to identify these lesions? Well, the big thing here is that we gotta make sure it's not cancer, which is present in 4 to 6% of thyroid nodules. And the worst cancer of the bunch is anaplastic thyroid carcinoma, embodied by Dr. Anna Plastic. That's right, we've tracked down the head crime lord of this entire iodine smuggling operation. And we have her island hideout completely surrounded. Watch out for those nodules, though. They may look like obsolete relics from the Cold War, but some of them are still active. Like a box of chocolates, you know? Never know what you're gonna get. Maybe nothing, maybe cancer. We'll see. To start this discussion, we're going to divide thyroid nodules into 3 major categories: non-neoplastic entities, benign adenoma, and thyroid carcinoma. Let's just play it safe and start with those non-neoplastic ones, shall we? The most common cause of thyroid nodularity is multinodular goiter, which you may remember from our Casino Rydell sketch. Long-term iodine deficiency causes recurrent episodes of hyperplasia and involution of the thyroid gland, resulting in irregular enlargement and nodule formation. I mean, just look at that guy. Crumpled and beat up and bruised. Just all around nodular looking. We also saw multinodular goiter in our last sketch at the graveyard, where we started autonomously producing excess thyroid hormone. This is called toxic multinodular goiter, represented by the same beat-up multinodular henchman. Just going rogue with that T4 time bomb. Well, here he is again. Taking a few more lumps, it seems. Looking as beat up and nodular as ever. Many patients with multinodular goiter will get further imaging with ultrasound, especially if the thyroid feels at all worrisome on physical exam. Maybe there's obvious asymmetry of the gland, or a focal area of firmness or tenderness. Though rare, that big mess of thyroid nodules could be harboring cancer. Any nodule that looks suspicious is usually biopsied to assess for malignant features. Sometimes the workup will include a radioactive iodine scan, also called thyroid scintigraphy. A big hint that a thyroid nodule is benign is if it lights up. These so-called hot nodules, which produce thyroid hormone and take up radioactive iodine, are almost never cancer. That's why we've added a glowing green disarmed light to the water mine. Nothing to worry about. Except the possibility of hyperthyroidism due to autonomous thyroid hormone production, of course. A cold nodule, on the other hand, is more likely to be cancer, and might need a biopsy and further workup to completely rule out malignancy. Just take a look at that cold, outdated water mine. Definitely in need of some further inspection. All right, a couple more non-neoplastic thyroid lesions to mention. That balloon up there is meant to evoke an image of a thyroid cyst. Cysts can be filled with serous fluid, colloid, or even blood. The majority of solitary thyroid nodules in women turn out to be thyroid cysts. Purely cystic lesions are rarely cancer, and usually left alone. However, if the cyst is really big and contains a mixture of solid and cystic components, it could be cancerous, and will probably need to be biopsied, just to be safe. The last non-neoplastic cause of a thyroid nodule is a focal area of thyroiditis, as symbolized by the flame on that thyroid bow tie. Patients with Hashimoto's thyroiditis, for example, can present with a focal enlargement of their thyroid due to an area of lymphocytic infiltration and germinal center formation. If you end up taking a biopsy, you'll see the usual mix of inflammatory cells and normal thyroid cells, and can rest assured that the nodule is benign. These patients are usually re-imaged a couple years later, just to make sure the nodule hasn't changed. All right, on to the next category of thyroid nodules, the follicular adenoma, embodied by one of Dr. Anna Plastic's henchmen, flying in to thwart the rescue mission. Let that plus sign on the side of the helmet remind you of the ad in adenoma. Follicular adenomas are benign neoplasms composed of thyroid follicular epithelial cells. In most cases, they present as a solitary, painless nodule. Follicular adenomas are, well, follicular, believe it or not. That net he's throwing depicts the typical histology. Sheets of normal-appearing thyroid follicular cells surrounding colloid arranged in uniform follicles. Similar to what you'd see in a normal thyroid specimen, actually. Follicular adenoma cells are separated from the adjacent parenchyma by a well-defined intact capsule. This is in contrast to follicular carcinoma, which has a propensity for vascular and capsular invasion. Excisional biopsy with evaluation of the adenoma capsule is the only way to distinguish between the two. Overall, the prognosis of follicular adenomas is quite good, as they do not recur or metastasize. Remember in our last sketch that a thyroid adenoma can rarely develop autonomous thyroid hormone production. What? These are called toxic adenomas and will show up as a hot nodule on a radioiodine scan. The overwhelming majority of follicular adenomas, however, are non-functional, meaning they do not produce thyroid hormone. All right, to complete this mission, we need to infiltrate Dr. Anna Plastic's hideout. But before we meet the lady in plastic herself, there are a few more guards standing in our way, each embodying a different feature of thyroid carcinoma. Time to get malignant. With most thyroid cancers, patients typically present with a painless mass. The most important risk factor for the development of thyroid cancer of almost any type is a history of radiation to the neck, especially in childhood years. So in comes our next henchman, donned in full radioactive attire, riding a jet ski modeled after our recurring cancer crab symbol. Notice, too, that he has a child in tow. A son of British royalty, no doubt. There are 4 types of thyroid carcinoma, 3 of which, papillary, follicular, and anaplastic, are derived from the follicular epithelium, and 1 special form, medullary, that's composed of parafollicular C cells. Let's start with papillary thyroid carcinoma, embodied by another henchman in a papillary propeller speedboat. Papillary carcinoma is the most common form of thyroid cancer, accounting for about 85% of all cases. Hence the number 1 finger our next captive is using to signal for help. It occurs about 3 times more often in women than men, with a typical age of onset in the 4th and 5th decade of life. Also, we mentioned radiation as a risk factor for thyroid cancer in general, but it turns out that papillary is the most common type of carcinoma associated with radiation exposure. The pathogenesis of most cases of papillary thyroid carcinoma involves the mitogen-activated protein, or MAP kinase, signaling pathway. The MAP kinase pathway is activated as a result of rearrangements of the RET and NTRK1 tyrosine kinase genes and point mutations in BRAF, the latter being the most common. Overall, these changes result in unregulated cell proliferation. Our recurring sketchy symbol for BRAF is Benjamin Franklin, of course. Hence the proliferation of Benjamin Franklin $100 bills from that briefcase. Money, 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 money! Papillary carcinoma can be solitary or multifocal, and it has a tendency to spread to cervical lymph nodes early, which can cause painless lymphadenopathy. Microscopically, papillary carcinoma forms papillae, or finger-like structures that are 1 to 2 cell layers thick around a fibrovascular core. Depicted here by the finger-like projections of purple algae covering the propeller blades. Notice the lack of visible thyroid follicles and colloid. Typically, it's unencapsulated, hence the open-air convertible design of the speedboat. In this sketch, when there's a capsule involved, we'll make it very clear with some kind of encapsulating windshield or barrier. There are 2 more very distinctive features of papillary thyroid carcinoma that can help you more easily identify it histologically, and are frequently tested. About half of papillary cancers contain psammoma bodies. These are formed from dystrophic calcification of necrotic cancer cells, which creates a distinct, round swirling collection of calcium. Kinda reminiscent of the swirling, overlapping petals of a rose. Psammoma bodies are rarely found in follicular and medullary thyroid carcinomas, but can be found in other cancers like meningiomas and ovarian cancers, to name a few. The other key feature to remember here involves the nucleus. The chromatin of papillary carcinoma cell nuclei is very fine, causing the cells to have an almost clear appearance. These nuclei are called orphan Annie eyes, because they look just like the, oh, mother of all that is holy! What is with those eyes? It looks like a serial killer dons Annie's skin each morning before traipsing around town, with a taxidermy dog puppet. Will tomorrow ever come is probably what people wonder when they turn around, only to see those 2 creepy eyes gaping at them like portals into a vacuum of complete and utter nothingness. Just take it down. Make it stop! Okay. Where were we? Yeah. Follicular carcinoma is the second most common form of thyroid cancer, accounting for 10 to 15% of cases. Notice the follicular net she's dragging behind the helicopter. It's 3 times more common in women and occurs mostly in the 4th to 6th decade of life. Interestingly, follicular thyroid carcinoma is more common in iodine-deficient areas, possibly due to the follicular hyperplasia and hypertrophy seen in goiter. In 40% of cases, Mutations leading to the activation of the oncogene RAS results in downstream upregulation of genes responsible for cell growth. So we've brought back our recurring RAS rat, the quintessential evil crime boss pet. Oh, who's my little tumor-ridden bundle of joy? Yes, you are. Yes, you Dick. Patients with follicular thyroid carcinoma most often present with a solitary, painless nodule. It tends to not spread to lymph nodes, but